So we're going to talk about pulmonary hypertension research, which I've been doing for a long time. We're going to talk about where we've been in the past and where we are now, and hopefully where we're going to go in the future. I can't ever get anything done without help. Pulmonary hypertension is not a disease for one individual. It is a disease for a team. And you can see here on the slide the physicians that I work with and the nurse practitioners and the research nurses and our RN who does all of our drug approvals. So don't think that we are successful because of what any one individual does. We are successful because of the group, and it's a team effort. So today we're going to talk about a few things. We're going to talk about the REVEAL registry and the Pulmonary Hypertension Association registry and talk about what those things have added to what we're doing and what we're doing now. We're going to go through how things have changed in research. Our goals in research and endpoints started at one point and how they've changed over time. We're going to also talk about new strategies to maybe make new studies a little bit better. And we're going to talk about a few drug studies that are ongoing now locally. So the REVEAL registry was back in 2006 to 2009, and it's the largest registry for patients in the world for pulmonary hypertension. It's a U.S.-based registry, and what happened is 55 centers in the U.S. with expert care for pulmonary hypertension and admitted patients to the trial. And basically, we collected information on patients. And there were about 60 variables that were inputted on each patient over the period of time of the study. And there were a certain number of patients who'd been historically had pulmonary hypertension and a certain number of patients allocated for new diagnoses. And this is all for WHO Group 1 pulmonary hypertension, what Chris talked about this morning. And it's a very special group, but this is really where we learned a lot. So what did we learn from the REVEAL registry? We learned a lot about pulmonary hypertension and basically what the patients were. We learned that 46% of patients were idiopathic. We didn't have any idea where they came from. We learned that there was a small number, 2.7% of patients, who had an inherited type pulmonary hypertension. And back then there was only one gene identified. Now there are two genes identified that are related to pulmonary hypertension. So even since then, this may have changed. We learned that 25% of our patients had connective tissue disease. We learned about 5% of our patients had liver disease that led to pulmonary hypertension. And about 5% back then were related to drug and toxins. Back then it was fen-phen, the drug that we had seen. Nowadays it's methamphetamine, and that number probably has changed as far as the number of new patients with pulmonary hypertension. HIV was a very small number, and we learned that about 10% were congenital heart disease patients who'd had surgically, at an early age, surgical repair and ended up with pulmonary hypertension. So that was something that we could not have said back before 2006. We learned how long it took to get a diagnosis because we asked questions about the patients. When did you first have symptoms? And when was your diagnosis made? We learned it was on average about 18 months, and that told us a lot. We were doing a very poor job of diagnosing patients with pulmonary hypertension. We learned like the common symptoms. Chris put them up on a slide today, the shortness of breath, and we were able to categorize that in patients and really know what to look for, and found out it was very consistent upon all patients with pulmonary hypertension. We also learned how sick the patients when they made the diagnosis. We found out that 75% of patients when they were diagnosed were functional class 3 and 4. And as you remember, those functional classes were 4, you're short of breath at rest, and 3, you have very limited activity. So we were diagnosing patients very late who were very sick. We also learned that who was using what medicine in what areas of the country, and that gave us an idea of how our patients were being treated, which we really didn't have a good sense for before. And also we learned how the patients were surviving because we followed them over about 3 years, and we were able over time to say, okay, these are the parameters that we're measuring, and came up with some information that would sort of say this is how long patients live and this is what their disease process is that helped us know things for the future. we learned that certain subgroups of patients with connective tissue disease can benefit from being screened for pulmonary hypertension. We know that early diagnosis for pulmonary hypertension is really important, and if we could pick out, which we learned, that certain populations develop pulmonary hypertension over a period of time, we could look at those patients to look for pulmonary hypertension in those groups. We also determined certain factors that we found that were very poor prognosis for patients, and things that are big red flags that say we should pay a lot of attention to these patients because they have characteristics that they're going to not do as well as other patients. And I think with that, we also learned that we weren't doing enough for pulmonary hypertension. There is a big number of things that were in this database, and they had a full-time statistician who crunched the numbers and came up with the things that came to the surface about all the different things we collected, which were important to know. That's how we know the 6-minute walk was important. That's how we know that BNP was important. Those things we were able to see in association with outcomes and survival in this patient population. So where are we now? What did we get out of REVEAL in the long term? Because it ended in 2009. So we identified the fact that we had not educated patients in pulmonary hypertension. Anybody who has anything to do with medical school curriculum knows that pulmonary hypertension probably gets a minute or two in the whole 4 years that you're in medical school, and when you get out of training, you get even less. So I think that that taught us we need to educate nurses, physicians, pharmacists, nurse practitioners. We need to educate everybody about the signs and symptoms of pulmonary hypertension and raise awareness in the community. And we were able to develop educational programs that have improved diagnosis times and actually helped patients and find patients with pulmonary hypertension. I went to a lot of places in small towns in Kentucky, and after I talked, somebody would say, "Oh, that's Mrs. Smith. You just described Mrs. Smith." And so we can find a patient with pulmonary hypertension that had been out there instead of 18 months being found and diagnosed. Maybe it was a year, but it was still pretty bad. We also were able to develop a risk calculator that told us what the prognosis is. By using the data from REVEAL, we were able to come up with the number of parameters and a scoring system. So when we see a patient when they're first diagnosed, we can put them in the scoring system and tell what the 1-year survival is, whether they're low risk, intermediate risk, or high risk for having trouble. And that sort of pushes us now in the direction of more treatment, less treatment. Treatment's fine right now. And that is really important. For this risk calculation that we recommend right now everybody does was not available because we didn't have a risk calculator before we had a registry like REVEAL. Right now, we are currently enrolling in the Pulmonary Hypertension Association registry. It's a registry that is to help study. It's a national registry that for the centers, accredited centers for pulmonary hypertension, and it's to collect information on patients with WHO Group 1 pulmonary hypertension and chronic thromboembolic pulmonary hypertension. It collects information at centers who are already accredited, and also it's to help people find out how they're evaluated, how they're tested, and observe what different centers do with participants, with the goal of trying to come up with guidelines to improve the care that the patients are getting. We were trying to determine what factors lead now in this modern day with new drugs, what's going to tell us that's going to make a patient worse, how are outcomes going to come. And that is very important because we got to keep expanding our knowledge. No matter how great we are, we still have patients dying with pulmonary hypertension. We really have to change this. So the Pulmonary Hypertension Registry, we call it the FAR, because we have a far way to go, I think. Patients in 2015 is when it started, and it's going to continue till 2025. Its goal is to enroll 3,000 patients, and right now there are probably a little over 1,200 enrolled. And if you're in our center, certain patients, if we meet the criteria and get you diagnosed early enough, we can put you in this registry. We have quite a few patients in the registry, and it helps to know what's in the registry. So when a center is accredited a second time and they participate in this registry, their data is compared to all the other accredited pulmonary hypertension centers in the country. And they get to see where they stand as far as, are you getting a VQ scan on all your patients? Well, you're at 40% and everybody else is at 90%, so you need to make a change. Are you doing echoes? Are you seeing the patients in a timely manner? Are you checking the functional class? Are you doing things that would show up in patients to make the quality of pulmonary hypertension care better? And once a center is going to be accredited, if they're not meeting the same standards that everybody else, okay, well, we talk to them about a correction plan and can improve the quality of care. And, you know, us doctors, we're always competitive. We don't want to be the last, you know, we want to be the first. So it's a nice thing to share the data with all the centers, and you can see where you stand. I think that the time for accreditation is a good time to discuss the FAR, and we bring it up at every place. The one thing that's been hard about the FAR registry is there's no money in it. There's no funding to pay anybody to put information in. For the Reveal registry, we got paid for each patient, and the person's time putting it in was really good. But for the FAR, it's really voluntary, and it's very time-consuming to get this done. We have to consent patients. Patients in here who are in it know you're consented, and then every time you come, you do quality of life. We do 6-minute walks. We do all this testing, and all that has to be entered in a computer so that we can know what it is and use that data to improve quality. So what have we learned from the FAR registry? I can tell you there are 11 publications right now that have come out of this registry. We're just going to talk about a few of them. We actually have learned things that are related to quality of life. We have learned that if you're female, your quality of life is better with pulmonary hypertension. Males don't do as well. We've learned that a patient with higher education has a better quality of life. We also learned that if you can walk further, those 6-minute walks, which you all love to hate, have told us that if you can walk further, you're going to have a better quality of life. So that's why we push exercise and do a lot of 6-minute walks. It also helps us in doing our risk stratification. We also have learned that underserved populations, Hispanics in the U.S., are not getting the same kind of care. They're more likely to end up in an emergency room and not necessarily get the same kind of care going to a primary care physician. We've also learned that they have more markers for severe disease. Also, palliative care. People think of palliative care and they think of end of life with cancer, but that's not really palliative care. Palliative care is a discipline that helps patients and caregivers set goals for patients and try to figure out where you're going to go. And we found that we're really not doing that. The only patients we had been sending to palliative care are patients who were older and that they couldn't walk very far, they needed IV therapy, they were on oxygen, they had a bad quality of life. And we were using it as an end-of-life thing, but we have recognized that a palliative care to help patients set goals and know where they want to be in the future has really changed what we're doing. So now when you're accredited, reaccredited for Pulmonary Hypertension Center or accredited, you have to have a palliative care network and you have to be helping patients set goals for themselves. We also learned that if you're overweight, the quality of life scores that patients have on our surveys is much worse. But if you're overweight, you're less likely to get a lung transplant. And we know lung transplant can be curative, but I don't think it's a good thing to compare those two because you can't get a lung transplant if you're overweight. So that endpoint may not be as interesting as we thought it was. But we do want patients to have a normal weight and not be overweight, because if you think about it, if you're overweight, you're carrying around 100 pounds that you shouldn't, and if you had to do that all day long, it makes your exercise tolerance less and you may have trouble. We also learned that there's a different mortality now. Patients are living longer, and that's big important to know that we are making some progress. They're still not living long enough, but we do know now that patients are living longer with pulmonary hypertension. So when we first started doing studies on pulmonary hypertension, what did we have? We didn't have good research like Reveal to tell us what things to measure. We really didn't know what is the most important thing. So the very first trial that was done was for IV epoprostenol. And that was just, did you live longer with it or without it? And that was a pretty simple trial. When the first oral drug came around, that was not going to seem to be a good endpoint because people got into the trial who were not as sick. And what they decided is, we'll see how far you can walk in 6 minutes. And the 6-minute walk for the first oral drug, Tracleer, had an improvement in 6-minute walk of 40 meters. And that was just over 12 weeks. So that was simple. It was good. It was an orphan disease. no drug will ever be approved again for increasing the walk distance. But while they did this trial, they looked at other parameters. They looked at some biomarkers from blood work, and also they looked at functional class. And out of this came the fact that we know that if your functional class improves with a drug, how much you can do at home on a daily basis improves, then you're more likely to be having a drug that works. So now functional class is really important part of our research. Later on, studies decided that, this is not enough. We did 3 or 4 drugs that got approved on improvement in 6-minute walk. And at the World Health Organization meeting in California at Dana Point many years ago, there was a lot of talk about, okay, 6-minute walk, that's not the end all. What makes the difference? Most patients don't like to walk, and how can we come up with something better to let us know? And so at that time, we talked about a composite endpoint, an endpoint that looked at a lot of different things. And one of those things would be death, which is a bad endpoint. Whether you needed atrial septoplasty, that's where they make a hole in the upper chamber of the heart to let the blood flow off without going through the lungs because the pressure's so high in the lungs, and that's sort of a release valve. And that can help some patients, but that's really pretty desperate surgery. Lung transplant, that's an endpoint. If you get a lung transplant, you're cured. Also, the need for IV or sub-Q therapy was also considered a part of an endpoint that we ought to consider, or if you had worsening of your pulmonary hypertension by a measurement that the study decided. So, clinical trial designs of testing and new therapies became large, placebo-controlled, event-driven trials. So you had to have so many events in the trial before the study could end, and you picked the endpoints before you started. And as things went along, you would see patients would get worse because most diseases say time to clinical improvement. All our studies are time to clinical worsening because we know our drugs will not stop progression of the disease. So we had patients receiving background therapy, and to get an answer, to get all these events, it would take 3 to 5 years in a study to come up with a number of patients that had statistical significance that we could say the drug worked. Well, 3 to 5 years in the study and 2 years at the FDA means that we are 7 years into a drug without having any results, and it's very difficult for our patients. We're waiting too long. Our drugs aren't where we are, so we really need to think about something in the future that's going to do better. So this is a trial. I use this trial as an example not because of the drug it is, but because it's the largest trial ever done in pulmonary hypertension. There'll probably never one be this big because it was so expensive. But this was one of those trials. The primary endpoint was a time to an event. And a statistician determined how many events had to happen to make it statistically significant to tell whether the drug worked or the placebo was better. And it had to occur over the treatment period, and it went on for years. The complications related to pulmonary hypertension were disease progression, hospitalization, the need for an IV prostanoid, the need for long-term oxygen, or the need for lung transplant or an atrial septoplasty. So those were the endpoints for this trial, and that's a lot of different things to try to pick up over time, but they had to be a lot of those, and it took a long time to come up with the events. In this trial, disease progression was defined as a drop in a 6-minute walk by 15% on 2 different occasions. So you had to have a second test on a different day, you had to have a worsening functional class, and you had the need for more therapy. And that therapy was not decided by the investigator. If I saw you and I thought you were sick and I thought we ought to give you more therapy, it had to be sent away to a committee that had to decide, yes, that's true, it's not true. And if the committee didn't agree, that was not considered an event. And then the investigator had to decide whether I'm going to pull you from the study and give you medicine I think you need, or we're going to keep going in the trial. And for this trial, about 20% of the events that were submitted to the committee were rejected as a true event. So this was a very rigorous adjudication, and so you just couldn't slip anything through it. So it took a long time. This is a very simple slide here. You can see how easy it was and all the things that had to be done. There were 1,150 something odd patients, and they were divided into 2 groups, and some patients got drugs, some patients didn't, and then there were all the breakdown of what happened to them. You don't need to read all this. You just need to know this was a very complicated process. So, and here are our results. You can see here that there's 36 months there, 3 years to come up with an answer. And what you could see is the patients who had placebo ended up not doing as well over time, and an event. Remember all those events: death, atrial septostopy, worsening of disease, worsening of functional class. And you can see that it took a long time to get there. And so patients who started on the drug, the good thing is the patients who got the drug in the trial had it for 3 years before anybody else, and it worked. The bad thing is the people who got placebo had to stay on placebo until they had an event. Once they had an event, they could switch to drug, but that was a long time into the trial. So the results in the end turns out this trial was really positive because of hospitalization. And it turns out that the trial was really driven by the need to be hospitalized. That was the biggest difference. And it just tells you all the things of the endpoints here, but it really was a positive trial because of the number of hospitalizations, not because of any other endpoint. And so that made people think, there's got to be a better way. We spent 3 years trying to get here and another 2 years to get the drug out to people, and that's a really tough thing. So we got to do better at what we're doing. And so what if? We got to have a different way to do things. And so what if we selected a higher risk patient population? Because if patients who are sicker and at higher risk, we could say you're more likely to improve with a drug than a patient who's low risk. It's hard to show a difference in a patient who's doing well already on 2 background therapies than a patient who has got a high risk for having problems. And what if we used a reveal calculus, risk calculator? We could pick out people, not that who are too sick to be in a trial, because you have to be stable patient to get in a drug trial. We could pick out people who had the potential, knowing from the risk calculator that in a certain number of months that they were going to get worse. And so if we had those patients picked out, then we could say, okay, you're the patients who should go in the trial first. You're the patients who can help us shorten this trial because you are more likely to have trouble in the future. With this strategy, the duration of patients taking placebo is going to be shortened. It will be less time. It won't be 3 years to get a drug to market. It can be potentially sooner to get these life-saving drugs out to patients. And that is something that we all really want. So what if we try drugs that target changes that happen in the lungs and heart? What if we try drugs that take care of vascular remodeling? What if we take care of things that can improve, drugs that improve right ventricular function? We know this disease causes death by right heart failure. We know this disease is an inflammation in the lungs. What if we stopped those 3 pathways being where we want to go and try to figure out new compounds that are going to change things up really big time? Because all the drugs that we have now are vasodilators, anti-inflammatory, and antiproliferative. But we know after all this time, not a cure, and doesn't arrest disease. It only can slow progression. Some lucky patients end up with 10, 15 years. Some unlucky patients end up with only 2 years. And so what if we try to change our focus and think differently about this? So new drugs need to target things such as immune dysfunction and vascular or cellular proliferation and right heart function. Those things we need to do. And if we can find other mechanisms other than vasodilatation, the clinical trials, that time to clinical worsening could be changed. It could change an endpoint instead of time to clinical worsening to maybe time to clinical improvement. We might be like everybody else in the drug industry, make improvements instead of just slowing it down. And we could hopefully improve the symptoms and improve the quality of life of our patients, also expand the number of drugs available in a shorter time. So right now, where are we? Where are we and what's going on? We already talked about the Pulmonary Hypertension Association registry. That registry is ongoing here in Louisville. We're putting patients in every few weeks if you meet the criteria, and we're collecting information. And that information goes to the national database, and investigators are allowed to send proposals to a committee that can say, yes, you can use this data to try to answer the question you've come up with. And that's why we have 11 publications right now out of the FAR data, because people have ideas, and not just one person has an idea. There are people in California and Minnesota and Florida, all over the country, that's able to access this data to be able to come up with new ideas about how to look at patients. Another registry we're involved in is the ROAR registry, or the Rio-Sequat Users Registry. And that basically is to say, okay, here we have a group of patients that have been on therapy, and all the patients have been on background therapy, 2 drugs. what happens to patients when they get this drug? What happens when we substitute a drug that changes a different mechanism in this patient? So if you're on sildenafil and tadalafil, that drug stops destruction of nitric oxide. We talked earlier in the day, nitric oxide pathway. Nitric oxide is good. We want more of it. It's a vasodilator, antiproliferative, anti-inflammatory. We want more of it, but those two drugs only stop destruction. What if you don't have any of that? So riociguat is a unique drug in it stops destruction of the nitric oxide, but it also increases production. So now we're going to look at patients who have been on those two drugs, tadalafil and sildenafil, and another drug, and see if there are changes, baseline measurements, 6-minute walk, BNP, and all the things in functional class, and switch them to this new drug and see what happens. We're going to see if in a large population we can make big differences. And if this works, we might change our recommendations on what the first-line drug is in that pathway. And I think that could be really important. I'm biased but what I think about the drugs, but I can tell you, an insurance company says, no, you got to try sildenafil. No, you got to try tadalafil. And then you can get Adempas. But if we can show information that by chance that this drug is a superior drug, then we could start with that and not have to go through the stepwise change in the drugs. Another study we're doing is an open label right now because we did the first part of this, and it's a new compound called sotatercept. And that is an injection that you take 3 times a week. And it has in past, in some pilot studies, shown to really reduce pulmonary vascular resistance and have significant improvement in patients. There are some people who believe that the animal studies with this show that this drug can stop progression of disease and maybe reverse disease. So that is an important compound, and it's a totally different pathway than anything we've ever tried. And so we're very, very excited about that, and that's open where we are now. There's another study which is a phase 2-3, which is a phase 2 study and a phase 3 study. It's a multi-center randomized, double-blind, placebo-controlled, adaptive design study to evaluate the efficacy of MK-5475 in adults with pulmonary hypertension. And that's riociguat that's inhaled. And basically, what we're doing is we are taking patients and doing exercise testing with a metabolic cart on a treadmill. We're doing a baseline, we're giving them the drug and seeing whether it changes. So they have one day where we do things and another day they come back and get the drug. And it's a one and done, but it's the idea to develop an inhaled drug that you can take like something you might take for asthma. There are rescue inhalers for asthma, and if the patients are doing activities that cause them to have trouble, you take that. And what if you could take a inhaled drug that works like a pulmonary hypertension vasodilator without side effects and can increase your activity, increase your ability to do things? That would improve the quality of your life. And you could take it when you're ready. If you had side effects from this kind of class of drug, you could take it as an inhaled drug and maybe not have the same kind of GI side effects you have. So that is a trial that we're doing. It's a very short trial, but it will open the door, if it works, to using this drug in a lot more patients. We're also doing a trial that is a study evaluating the long-term effectiveness and safety of ralinepag in patients with pulmonary hypertension. And there's an open label extension. And this is another prostacyclin pathway drug. It has different characteristics than the other one out there, the other two out there. It has a less toxic side effect profile, they say. We never know until patients take it in the real world, but in the trial it's doing that. And to look at whether or not this dosing is easier for patients and not having to take something 3 times a day. And that could be something they could use. But again, it's not really new and innovative, but it's another thing that we could have in the tool chest to be able to help patients. We're also doing a randomized, double-blind, placebo-controlled dose escalation and verification clinical study to assess the safety and efficacy of pulse nitric oxide in subjects with pulmonary hypertension associated with pulmonary fibrosis. Well, this is not WHO Group 1 pulmonary hypertension, and why do we care? Pulmonary hypertension in any form, whether it's WHO Group 1, 2, 3, 4, or 5, ends up with higher mortality in those patient populations. So if you have that, doesn't matter what else you had or what the cause is, pulmonary hypertension, you're not going to live as long. And so people have a little machine that generates nitric oxide. We know nitric oxide is good, a vasodilator, and we're going to see if that helps these patients. We have tried this in pulmonary hypertension. The big problem is patients wouldn't wear it long enough. Well, you need to wear it about 20 hours a day, and they just wouldn't wear it 20 hours a day. So that trial in WHO Group 1 patients didn't work, but I think in this trial in pulmonary fibrosis might work because the majority of those patients are on oxygen already, and it was added to the oxygen, so that might work. There's another study we're doing. It's a phase 3 prospective, multi-center, double-blinded, double-dummy, randomized, active control, parallel group sequential, adaptive, event-driven study to compare efficacy and safety and tolerability of mastaxanthin, which is Opsumit, versus Opsumit at a lower dose for patients with pulmonary hypertension. Now, what does this mean? That's a very complicated thing. So patients start off on one dose of this drug, Opsumit, and they have a run-in period. And then we're blinded, and they're either getting 75 milligrams of the Opsumit or 10, and then after a certain period, they're switched, and the people who are getting 10 get 75, and the people getting 75 get 10 milligrams, and we're seeing how that works, and at the end, the people who did okay can have 75 until we get to the end of the study. So that's very complicated, but the thing here is that we think that endothelin pathway, which is what Opsumit takes, may not be totally blocked. And if we could give a much higher dose of the drug, we might be able to block it better and do much better as far as progression of disease. There's another study we're doing which is kind of interesting, and it's a retrospective study, and it's evaluation of pulmonary hypertension patients. It's a real-world experience, and it's TRIO, and basically it's a network that is collecting data on drug use and certain parameters from historical patients that we have, and the information is being sold to pharmaceutical companies. And that information may tell them, and insurance companies, to see what the practice patterns are and what kind of results we're getting that's not prospective, which means looking toward the future. It's looking in the past. Another trial we have is a phase 3 randomized, placebo-controlled, double-blinded, adaptive study to evaluate safety and efficacy of inhaled treprostinil in patients with COPD and pulmonary hypertension. So you have another group, WHO Group 3 pulmonary hypertension, who has patients with COPD. And COPD, pulmonary hypertension, really affects their life, and we are giving them inhaled treprostinil, which is used for WHO Group 1 patients, to see if we can improve their quality of life and 6-minute walk distance and health. There's another study we're doing. It's a phase 2, double-blind, randomized, placebo-controlled study to evaluate the effects of sotatercept in patients who have WHO Group 2 pulmonary hypertension. So that is for patients who have heart failure with pulmonary hypertension. So we have a couple more studies here. Time is running out. The one I do want to mention is the Gossamer study, which is a drug that is looking to change the fibrosis in the lung and to change the progression of disease, and we're hopeful that that's going to stop the progression of disease and maybe reverse disease. So these are the trials that are here. This is not all the trials we're doing. We have 18 trials going on right now, but this is some of the high points and things that we have for research in the future. But just remember, we started at a point that's pretty simple, and we went to a place that's very complex, and now we're at a place where we're trying to get answers sooner and get drugs to you quicker. So I hope it wasn't too much, too fast, but you haven't learned what adaptive double dummy blind is, and I'm not sure I know either. So thank you for all your attention. If you come to our office, you're screened every visit to see which trials you can fit in. So, and if you're not in our office and you're interested in these trials, you just contact us, and thank you very much.